Okay, it's 7 p.m. Let's start. So, good evening. This is Babak TV from New York City. 7 o'clock daylight saving time, Eastern time. Hope you guys are all safe. We are having our fourth session of virtual tumor board remote learning. This session is very special because we have a special discussion related to this time. Dr. Andrew Schumann from University of Michigan will present cases, and Dr. Susan McCammon from University of Alabama, who's an ethics specialist, and Dr. Arnold Bewley and Dr. Michael Moore will be the discussant. I hope that other faculty will join in and participate in the discussion. Please feel free to ask any questions and send your comments to me. You can use the chat box and I will relay it to the group, or you can just unmute your phone and participate in the conversation. This 7 p.m. right now, and I don't know if you hear the noise outside, but that's the people cheering, the healthcare workers, people like you. So thank you for everything you're doing. And Andy, you start.
Great. Thanks, everyone. You can hear me okay? We're good? You see the screen and hear me okay?
Yeah, we're good.
Perfect, great. Okay, thanks. I hope everyone is safe and look forward to this session. So we're going to start with a first case. This is a 54-year-old man who is prior completely healthy. He's admitted critically ill with COVID. He has a SOFA score of 8, was intubated 9 days ago, has had gradually progressive sedation needs, and his blood pressure titration has become more challenging. And the intensivist taking care of him has requested a tracheotomy. For the purposes of this discussion, let's assume you have adequate PPE and there is availability of equipment and supplies to perform this procedure.
Okay. And so Arno, have you had this situation before? Arno, can you hear me? All right, so this is a common scenario for us. We have had quite a bit of these cases at this point. Our general rule is we treat them like the rest of the ARDS. And if they are usually in their second week, if they are otherwise stable and weaning off the ventilator is the main issue, they require a lot of sedation. We do consider doing these tracheostomies. We do have a protocol for that just the one attending and the senior resident with adequate PPE, which for these cases would be, we either use cappers or we use N95 plus face shield, double gown and gloves in the MICU or SICU room. 9 days is a little bit early for us. We usually wait at 10, 11, and we would work closely with the ICU attending. If the patient has a reasonable outcome, we are not we don't obstruct the trach, but if the patient is really critically ill and on 7 different pressors and going to kidney failure, we don't rush the trach. We think that the outcome is not dependent on the trach. That's our approach here. Any other of the attending who would like to discuss their approach? Jeff?
Yeah, I mean, this is Mike. I think one thing that's challenging in these scenarios also is the lack of family perspective, and obviously a lot of that involves in getting them on the phone because they're not in a position to be in the hospital. Obviously every patient and every family will have different thoughts about the option of tracheostomy, and obviously a lot of those also may center around the ultimate trajectory of their clinical course, but I think that's a big part of it too, is kind of getting a sense of, the family's thought process. And obviously the ICU would have probably already entertained that when they consulted you, but I think it never hurts to involve them in the discussion to make sure everybody's on the same page.
Okay. Susan, would you like to make a comment now or later? I agree completely.
Sure. So, from an ENT perspective, our department has worked towards a protocol, and we've worked in an interdisciplinary way so that all of the folks in the hospital who are doing tracheostomies are on the same page. So, interventional pulmonology, the intensivists, the trauma critical care surgeons and us, and we really, elect to defer tracheostomy or tracheostomy manipulation as much as possible in the era of COVID. But as you said, for folks where the ability to wean from the vent and measurable progression is evident, then we don't obstruct that, and we use our maximum PPE or PAPR. In terms of it, family and advanced care planning, I think that from putting on my palliative care hat, we've certainly moved way upstream in talking to our at-risk patients about how their advance directives would change in light of COVID. And we've really pushed hard to have availability of telehealth at the bedside so that families can witness the visual aspect of critical care, which is so powerful in decision making, I think, when they're able to be at the bedside. So that's my perspective at this point on this case.
Okay, very good. Andy, please proceed.
Yeah.
I think one of the considerations here is how standard of care and standard practice has evolved a bit. It's interesting to hear different perspectives on that. At Michigan, we are not in the situation that our colleagues are in Manhattan, but we are quite close to the surge in the Metro Detroit area, and our ICUs are filling up rapidly. We've adopted a bit of a hybrid approach in that for patients with a compelling indication, such as difficult BP titration or other reasons why a tracheotomy is absolutely necessary for their care, we are indeed performing those. But for the more quote-unquote elective trach in the setting of anticipated prolonged ventilator dependence, we are delaying those to a minimum of 3 weeks, and that is purely based upon considerations to limit aerosolization if and when possible. So I am not by any means suggesting that that is the right answer here. I don't know that any of us knows the exact right answer. I'm going to briefly talk about why these decisions are a little different. When we think about patient care, whether it's cancer-related or critical illness, we're generally making decisions in medicine based upon the primacy of the doctor-patient interaction and the best interest of individual patients. However, the COVID era has created a situation in which public health ethics has superseded the way we think about individualized patient choice. And this in and of itself is incredibly uncomfortable for clinicians who are basically trained to do what's best for the patient sitting in front of them, especially from a privileged setting. We all know the need to flatten the curve. We all know the need to limit aerosolization. That goes without saying. I think what is hard to reconcile is the fact that patients can and will be disenfranchised and even hurt by those decisions, whether it's delaying cancer care or whether it's delaying tracheotomy or whether it's performing procedures in a different manner than we did, even simply doing things in a different setting with different people. And we're not very good at delaying care. And we are also not very good at rationing at the bedside. One of the challenges here is that medical decision-making, generally speaking, is based at the bedside. However, when we are making decisions that are more focused upon a public health good, it requires us to take those considerations into light. Generally speaking, when we are making public health decisions, though, they are not based on individualized choice, but rather are made more cohesively as a service or a practice or an institution. I'd refer you to Dr. Givi's lead authorship for a very nice review of these safety recommendations and how they take this into account. And there's a nice piece that came out from the SARS epidemic that informed many of the workflows for how we actually perform these tracheotomies, also published in JAMA Odo. It seems like there's a couple folks who haven't muted their mics, so if you can just double check that you're muted, feedback will decrease. Thank you.
That would be great. Thank you.
And then there's also a couple of papers that have literally come out within the past 2 days. I suggest that you take a look at the AHNS COVID page as well as the AAO COVID page, which have some more guidance for tracheotomy specific decisions. When we apply these ethical decisions, We balance doing good, listening to patient voices, avoiding and mitigating harm, and doing the fair thing. The problem, though, is when we're dealing with pandemics and critical shortages, these principles directly conflict, and the challenge in weighing individual patient interest versus the welfare of everyone becomes very tense, and which is why you're hearing different perspectives on this from different people. And as we go through the next few cases, these themes will come out even more. Any further comments on that, or generally speaking?
Jeff and Don, I saw that you're on the line. Would you like to make any comment about the tracheostomy specifically for COVID patients?
Yes, sorry I joined the call late. Andy, nice to see you again. Thank you for leading this ethics portion, which I know you're an expert in. I just wanted to make a comment about tracheostomy in COVID patients as a case that was presented. I think a lot of that discussion depends on the institution that you're at. So if you're at an institution that is a couple, let's say 7 to 10, 7 or 8 COVID patients in-house, sort of managing a very low volume, as it were, it'll be a little bit more ad hoc from a treatment standpoint. Where I am in Philadelphia, we're one of the busiest COVID hospitals at Temple University. I know where Babak is at, in some of my friends in Manhattan. I mean, it is all COVID all the time. And I think when we have that amount of volume of patients coming through, actually the request for the work is much more protocolized, that there are criteria that establishes whether tracheostomy is a reasonable consideration. And it's sort of a broadly applied as evidence-based as possible across, every patient. In order to keep the resources consistent, that it's not an ad hoc decision on a case-to-case basis, but more like a protocol or at least team-based decision, as was previously mentioned. But it's because it's so high volume, we can't just trach everybody. And for all the risks that were discussed, we're not traching early like we would usually do for patients in the respiratory ICU.
I completely agree. That's definitely at the minimum what we need to do. And as Jeff and Andy said, there are some that you have to tailor to your institution, but at the same time, there are some universal precautions. If you do a tracheostomy without an N95, you're putting everybody at risk. If you're doing a tracheostomy without doing the protocol of stopping the vent and all the other safety procedures, you're putting everybody and all the patients and all the nurses afterward at risk. This is an extremely contagious disease. I have my colleagues that one person coughed in their face and they got COVID. So don't underestimate it. And I completely agree that you have to be very, very careful. And a lot of physicians will become sick or will get this disease. Okay, Don, do you have any comments?
Yeah, the only thing I would say, I echo what was said about making sure that you address the multidisciplinary trach provider issue at your institution. I think we have a very keen interest and we as a specialty have clearly looked at this from a protocol perspective. I think many of our colleagues in other disciplines who perform trachs have been less vigilant, at least from what I have seen. And so trying to get everyone on the same page at your institution from a safety perspective and from a protocol perspective as to timing is really, really important. The only other thing I would say is protocols are protocols. Individual patients still do need to be evaluated on an individual basis when it comes to, really understanding why the request is being made.
Sure. Okay, excellent.
Quick
All right,
question.
Andy, let's go.
Can I ask just a quick question?
Sure.
Babak, our MICU here does historically a lot of their own PERC trachs, and there's been some discussion, is it safer to keep the patients in the ICU, do the PERC trach there rather than transporting to the OR versus or is it safer to transport patients into the ICU?
That's an excellent question. In general, if you can do the trach safely in the MICU, there's no question that is safer. Just transferring a patient, a COVID positive patient across the hospital is not an easy process. If you are transferring a patient, as we said in that paper, you cannot just transfer him with a trach with just a ambu bag. You're gonna spray the virus all over the hospital. You have to take your ventilator with the patient all the way to the OR. The circuit should not be broken at all. So based on that, our service, ENT, we actually do all of our trachs at the bedside. And we do have a protocol that basically the the link is not, the circuit is not broken at all the entire time. And every time we switch or open, the vent is completely off until we reconnect it and take it out. But if there is a place that you cannot safely do them in the ICU, I think with adequate preparation, you can transfer them to the OR. But majority of tertiary care places, we do have enough expertise and equipment to be able to do them in the MICU. I personally, I think from logistical standpoint, it's better to do them in the ICU.
Thanks.
Okay, Andy, please proceed.
Okay. Second case, we're going to switch gears a little bit. This is a 47-year-old man who's homeless, presents with progressive dysphonia. He's an active smoker, fairly healthy other than underlying hypertension. He was diagnosed with a T2 glottic cancer of the true cord 2 months ago at another institution. And due to his turbulent social situation, he is a truck driver and is homeless, did not proceed with treatment at that time. He presented to our institution with progressive dyspnea on exertion. He's not in extremis by any stretch, but he's certainly getting tight. On exam, he has soft inspiratory stridor, but is not in distress. He has a large, bulky transglottic lesion with a borderline airway on scope exam, and imaging reveals a bulky transglottic cancer. We talked to him about treatment options, and his exact quote is, "Doc, I can't have a hole in my neck. I live on the streets of Detroit." He presents essentially right when things are starting to get bad with COVID at our institution. But I'll leave it there and we can talk through options.
But at this point, he's not COVID positive.
He is not COVID positive, has no known sick contacts, but is extremely high risk in that he lives on the streets of Detroit.
Sure, absolutely. Okay, let's open to discussion. Who likes to go first? Arno, can I pick you up first? Or how would you approach this?
Yeah, I mean, I think this brings forth, I think, Andy's previous comment of the kind of ethical dilemma of weighing, the risk to the individual and, proceeding with standard of care versus how do we reassess individual decisions in the setting of a pandemic where we have to weigh the risk to the, overall population. And I think what makes it particularly challenging is that risk is very dynamic. I mean, every week we learn more information. And it's also heterogeneous across the country. I mean, in California, it's a very different thing versus New York versus Detroit. Here, I would, because we've had such a low impact of COVID patients, I would really prioritize the individual still. And I would, treat him with basically typical standard of care, which would be, offering a laryngectomy, potentially tracheostomy in the short term, and really trying to just focus on what he needs.
Go ahead, please.
I was going to say that I'm going to steer the discussion first for pre-COVID, just sort of in our normal day-to-day. Andy, it's like you looked in my practice and picked out a patient I see pretty commonly, which is an individual with a advanced larynx cancer to a degree, but a significant social support missing that makes treatment feasible. I think as a team, we always try to find what is the best treatment for patients first oncologically, and then we sort of take the next step to say what is feasible for the patient, and then bring in the patient autonomy. I think it's important because having worked with a lot of different teams in the past, I think sometimes when you bring in the patient preference before you really establish the oncologic requirement, it muddies the waters very quickly. So it's okay to say, I think there's a discussion here whether or not an upfront laryngectomy for a patient whose larynx isn't functioning compared to organ preservation with chemoradiation would be the appropriate next step. Let's just go with a non-surgical treatment since the patient doesn't seem to be an extremist just as a first step. If the recommendation is chemoradiation, then you have to ask the question, how is a homeless individual who has few resources going to show up 5 days a week for 6 weeks and get chemo, even on a weekly basis? So I think that from an initial approach, I think it's important to first oncologically define what your best preferred treatment would be, and then you can start to make your alternative recommendations in conjunction with the patient, respecting patient autonomy, but also oncologic outcomes. So, just tracking the patient and saying we can't help you clearly would be inappropriate. A consideration for an upfront laryngectomy would be hard because you would have to breathe through a hole in the neck and not be able to talk. But then if you can't also show up, so you're stuck between a rock and a hard place in many ways. And then I think you have to work that problem in the best way possible. Maybe to get him into a homeless shelter that'll cover him for the next 6 to 8 weeks, getting your social workers involved, and really bringing in your team to support you, at least
This is a great case and a really difficult conversation, difficult decision making. I would invite Susan, Mike, and Don, other discussants. Would you like to make a comment on how you would approach this problem?
What is his? Oh, go ahead, Susan.
No, please go ahead.
I was just asking about his laryngeal function because he was originally stage T2, and now we know it's transglottic with some stridor. But does he have? What is his exam besides a tight airway?
Sure. Otherwise, this actually looks amenable to an organ preservation approach. He's eating and drinking just fine. His airway is threatened, but by no means acutely obstructed. Some nuance to this case is that, in my judgment, I think he can get by for now, but if he were to get radiated, I would worry that this would obstruct fairly quickly. And another wrinkle here is that we can give him local temporary housing where he'll be able to stay through radiation, but not if he has a trach.
Yeah. Actually, this is very similar to a case that I did with one of our residents today at VA. This patient had a massive base of tongue, unresectable, and he was supposed to go get chemo RT. It was delayed and came in last night drooling, and there was a tight airway, and we basically trached him today. But at this point, we are, the VA is different because they can have some support afterwards. But these are very difficult cases. I agree. Susan?
So I think the ability of the institution to provide housing and social support for non-surgical treatment is critical here. And that varies across the country from, really robust to zero. Based on my experience with patients in this situation, they do better with a laryngectomy. And they, preoperative counseling that can, address their fears about, the stigma of the stoma and the question of speech and TE speech and the ability to swallow. I think that the risks associated with incomplete or broken radiation therapy are really greater. And then you asked the question, discuss treatment before and during COVID. And I'm not sure how different that is, really. I mean, patients with an open neck airway, either a trach or a laryngectomy stoma, are perceived as higher risk. But I don't know that would really make a big decision and a big difference in my decision making here. He doesn't have COVID, he has a cancer, I want to treat him the right way. I would really focus on his social situation and his ability to successfully get through radiation or chemoradiation.
Yeah, so that's a great point, but and I would follow up on that. I'll say 2 pieces of evidence. Number one is, as you have heard about that famous case in China, that is a transsphenoidal pituitary, and the patient was in the pre-symptomatic time, and 12 people got infected. So in high areas like New York City right now, we basically, anybody that's not tested, we consider them positive. If this patient is going to the OR, we would consider him as COVID positive. We're going to have full same PPE that we have for a COVID trach, basically.
Whether or not you have testing, would you test? Would you believe the test?
If we test the patients the morning of the surgery, if it's elective, or the night before. But if it's an emergency and we can't, we treat them as COVID positive. And
Right.
then number two is, you know, I completely agree with you in regards of he probably going to do better with laryngectomy. But another piece of information for our fellows is there was a paper that came out that, again, I think from China, that showed people who were in their pre-symptomatic time and they had an elective case, they had a very high mortality afterwards. So if you are doing a definitive treatment here and the patient is not in extremis, I would highly recommend that you consider that, make sure the patient is not actively infected. And if that's infected and then you have to do the laryngectomy, I would wait for 2 weeks. All right. Okay, Andy.
So we improvised a little bit here. We actually, because he had a housing opportunity in town, but not with a trach, we rolled the dice and I gave him induction chemo. And he received TPF and literally today saw him back and his tumor has melted. So we are planning a definitive CRT now that he has an open airway and will house him locally. Now, I hope and pray we don't get into Susan's concern that he will not make it through treatment or persist or recur. But I think an outside of the box approach of induction in this case seemed appropriate, and I hope it works.
Actually, at this point, I don't think it's out of box. You know, I don't know how many times I've quoted the Michigan paper about induction chemo at chemo selection. And I think we have enough evidence
right.
And I think that's a very, very reasonable way to approach it.
I totally agree. And we use induction for bioselection all the time. I guess my point here is the reason we used it was simply to be able to expedite care in the COVID era, less so than for bioselection, purely speaking. But yes, we are certainly drinking the Kool-Aid of induction here.
Yeah.
So Andy, can I ask a question? How would this change if he tested positive for COVID? He has a potentially curable cancer, and let's say he's COVID positive and maybe not in extremis. He's not needing the vent. He's just, sick, maybe one of the mild cases. How would your decision making change in terms of immunosuppression and time to treatment and infectivity? Because I think that's really what's on our minds right now. Well, how do we manage these patients in the era of COVID? So.
Yeah, I mean, I think Bob cited the only paper that we have on this, which is that outcomes are way worse in that setting. I will also admit that I'm to some degree interpreting that data on the fly. I think in that situation, I would delay treatment for at least 2 to 4 weeks and cross my fingers that his tumor won't progress, but would not start treatment in someone who is actively sick with the virus. If he needed a trach for airway, that would change things. In that case, he would indefinitely be in our isolation unit with that trach under observation until he's recovered enough to either be de-escalated or to start cancer treatment. But that would be an incredibly difficult situation. Luckily, I haven't had COVID positive patients with high risk cancers yet.
And
Don?
if he required ventilation, would your ventilator allocation committee take his treatable cancer into consideration, in line with the ASCO paper that you distributed? Do you think that would be a factor?
Yeah, give me 3 slides and I'll answer.
All right, bring it. Thank you.
All right.
So
I think Don had a comment.
Sorry, go ahead.
Before you go, Don?
I was just going to say it's super important in this case. I think it's a great treatment algorithm for this particular patient, and I've treated similar patients that way, whether refusing trachs or what have you. That said, the patient certainly needs to be tested before chemotherapy is started in this case. Just as if he were going to surgery, he would need to be tested. We're testing all of our patients twice, and even there we've had positives return after negatives. So
correct.
It is a roll of the dice regardless, but you've got to at least try to find out as well as you can whether or not inducing him with chemo is going to tip him over the edge, and that would be terrible too.
I completely agree. And, you know, a couple of weeks ago, I brought this up in our institution, and they would say, well, we don't have enough tests. Well, we're not doing, if they're asymptomatic, we're just going to treat them. But now things have changed, and we do also, for any treatment really, especially chemotherapy, not radiotherapy may not that much, but we do test them now. I agree with you.
And I think that will be regional depending upon the availability of testing. There's clear disparities in terms of access to tests that will influence that decision, but I fully agree. I'm going to dovetail a little bit on what Dr. Weed and Dr. McCammon and others have already alluded to, which is the idea that we have to be consistent, and being consistent and cohesive is actually a key component of ethical treatment. And I'm going to give you a brief example of why. Dr. Smith practices within an institution, is a cancer surgeon, and takes care of mostly high socioeconomic status patients at the mothership of the hospital, and has made a determination that treatment of cancer to a large extent supersedes the need and the ability to delay care for COVID while still practicing within the realm of what is acceptable at the institution. She's pushing the envelope for more aggressive cancer treatment. Dr. Jones works for the same institution in a facility across the city where most of the patients are poor and underrepresented minorities, and has made a different decision and decided that most pressing is the need to flatten the curve and delay as much treatment as possible. Both of them are being consistent individually. Both of them are practicing as ethically as they can. But what you can see is this is engendering major disparities in care as a result. So the need to be consistent, just as the folks on the call have made clear, is actually a key ethical tenet. And the need that that happens within our sphere of influence is critical. Now, we're now talking at the AHNS level. This may be at the individual institution or provider level, but coming to some consensus is important. Dr. Weed also guessed at my fourth bullet here, or knew it was coming. Which is that we are still doctors, and we still need to take individual circumstances into account, whether it is a homeless man from Detroit or a wealthy doctor from the suburbs. Those things matter, and those nuances will influence care in ways that will obviate the ability to be consistent for everyone. But having a consensus plan at the institutional level, whether it's protocol-based or not, is critical. One challenge is that we're not very good at rationing for individual patients when they're our patients. So what that means is that rationing criteria, if and when we come to allocation, as Susan is bringing up, needs to transcend that dyad, meaning that the person making rationing decisions cannot be the individual taking care of these individual patients. This is a quote that came from New England Journal last week from an oncologist in Utah. I'll let you read it, and I'm happy to share the slides. But the argument is that my queasy conscience wrestles with the possibility of a bimodal peak of cancer patients dying, those dying of COVID, and then a latent toll of those whose treatments were de-identified, delayed, or canceled, and to survive the virus, only then to succumb to COVID or to cancer is a Pyrrhic victory. There's some beautiful guidance coming out of multiple societies. ASTRO, ASCO, American College of Surgeons, and the Society of Surgical Oncologists. All of these are hyperlinked, and I'm happy to share the slides. Have very nice sets of guidance for management. I'll talk a little bit about the ASCO ones, as Susan alluded to. These are straight from a paper that came out last week. That's a consensus statement that's published in JCO. Cancer needs to be individually considered with treating oncologists, and that cancer should not be considered a comorbidity that obviates escalation of care unless that is appropriate to that individual circumstance, and that decisions for allocation need to be separate and above from the bedside. All of these are consistent with what we've already discussed. Finally, that oncologists, surgical, medical, and radiation need to work within their institutions to determine how best to allocate and how best to approach these very difficult conversations with compassion and honesty, and that goals of care are an important part of this conversation. We need to talk through what people would want if they were to get critically ill before that happens, especially if they have life-limiting comorbidities, including cancer. There's a set of guidelines that I had the privilege to help write on behalf of our Ethics and Professionalism Service. These are all posted on ODO-specific resources. AAO has a page, Head and Neck, the journal has a page. There's the AHNS COVID Bulletin, which hopefully many of you have already looked at and contributed to. Canada has a nice one as well, the Canadian Otolaryngology Society. And again, all of these are hyperlinked. Comments or questions before moving on to the next
so there are a
case?
couple of very good questions came in from the audience. That was excellent, Andy. Thank you so much for all the resources. So question number one from the audience is, how would you manage the tracheostomy afterward in terms of making sure that the patient doesn't get infected, because now they have a basically unprotected airway, or if they are positive or under investigation, they are not infecting others? I will tell you, in New York, it's still very much evolving issue. Basically, we do not have their trach open at any time. At any time, they should have an HME filter or something there, and it's covered. They are still, if they are a COVID positive, they will be in isolation in the COVID ward. The ones that have a tracheostomy and they are COVID negative, they are very high risk. So we try to protect them. Hopefully there aren't that many of them, but we have to be very, very careful with them because they are extremely susceptible. There are no universal protocols yet. As I said, there are the HME filters to reduce the aerosols. We don't have a viral specific filter on the tracheostomy yet. There are some viral filters in the ventilators. So it's a huge challenge. I'm interested to hear from others. Have you figured out what to do with these COVID positive or COVID negative patients with trach?
I don't have a.
Oh, go ahead.
No, I was just going to say I don't have a comment for the trach specifically, other than patients cover as well as they can that are COVID negative and isolate. And if you're in our hospital anyway, we treat every patient as if they're COVID positive. If we know they're COVID positive, they're obviously in a COVID unit, but every other patient room staff treats those patients as if they're COVID positive.
Yeah.
That said, the only thing I would add, this is not so much an ethical issue, but it's something that we have to be very cognizant of as head and neck providers, and that is the idea of the potential for COVID positivity, regardless of your testing. If your testing is negative and there's false negative, et cetera, and the added risk of what could happen to a patient with whatever treatment they initiate, whether it's chemotherapy or surgery, that now needs to be an integral part of our patient care discussion about what are your options for treatment, because that's a new risk that patients have, just like heart disease, et cetera, that really has to be at the forefront of your conversation.
I want to circle back about some of the slides that Andy talked about having sort of looking at society or sort of like consensus guidelines for management of patients with cancer in the setting of COVID. Andy referenced the multiple societies. When they canceled elective surgery, we had a difficult time figuring what was elective and what was still urgent or necessary when it came to cancer treatment. And within two spaces, it was very helpful to see this, the SSO, the Society of Surgical Oncology guidelines of the website I'm posting right now. If you look at the bottom left of the page, there's some disease-specific guidelines specifically for head and neck melanoma and endocrine that helped make some decisions for some of the patients I was treating at the time. The diagnostic lobectomy, the low-risk papillary cancer, the early-stage T1A melanoma resection. Those are some of the examples of patients' cancers that could be delayed, recommended for consideration for delay. So for those of you out there who are thinking about how do I manage these two competing challenges of COVID-19, resource management and taking care of timely treatment of cancer patients, within some specific disease sites, there are some solid guidelines to help frame that discussion. So thanks for bringing them up a little bit earlier.
Thank you. I agree. That's the Society of Surgical Oncology usually have very good results. Okay, so we've got 20 minutes left. Third case is very interesting, and I really want Andy to have enough time to discuss this. It's a very timely case, and this is something that if it hasn't come up to your department, it will, because I am dealing with it at VA every day. Go ahead, Andy.
Sure. So this is the case of a 40-year-old head and neck surgeon who practices in a small city where this individual has one partner. The two of them are doing the vast majority of head and neck surgery. The doctor himself has a history of bone marrow transplant for a lymphoma and is now dealing with graft versus host disease and is steroid dependent. He's been asked to perform tracheotomies on critically ill patients with COVID, as well as take care of his normal load of cancer patients. And he is highly uncomfortable and conflicted regarding his own risk and the risk to his family, as well as his obligation to take care of his patients.
Would you like to open the discussion yourself, Andy, in terms of like what the question you have for the audience?
Sure. So, I mean, very broadly to start at least, how do we balance vulnerability and high-risk clinicians with our obligation to take care of patients? To some degree, I made this a little more difficult than others. So, for example, if you are privileged enough to be in the setting where there's redundancy in providers, perhaps providers can focus on the non-COVID infected patients and have the higher risk procedures and patients see someone who is not potentially at that high risk. But the example I'm giving here is one where that is not as easy said than done. So for many of you, perhaps you have similar circumstances, and that might involve parents who are living with you or other higher risk medical conditions.
Yeah.
I will share bluntly myself that I have my two parents living with me now. They moved to Michigan to get out of New York City before it got bad there. And they both have medical conditions, and that hasn't prevented me from going to the hospital, but it's certainly something that we think about.
Absolutely. And we have multiple number of, not in our department, but other departments that folks basically don't come in. They use their time, especially sick time, and they get a letter from someone that's saying, oh, I'm not taking care of COVID patient, and that's putting extra burden on others. Now, obviously, your case has a very reasonable reason for that. Okay, how would you approach? So let's put our leadership hat on and see how would you approach that. Let's see who are the senior people. Mike, you go first. Okay, Jeff, you go first.
I'll take a first stab at this. I mean, the setup here is a challenge, as everyone can appreciate. Let me just try to frame the salient points. It really is a duty of service compared to the duty of the individual for safety. I think are the two competing interests here. I think I'm going to come down on the side as the risk of the individual is the priority for being addressed. None of us would throw ourselves off a cliff, involuntarily to serve others. Would be a personal choice. And so I would say that for this surgeon who has a high risk if exposed to COVID, and given the risks of COVID, has an individual choice to make in terms of whether he feels comfortable not serving. And if he, in his choice not to serve needs to be respected, because none of us, I think on this call, have the right to tell other people what to do against their will. Many of us are willing to step up in dangerous situations, in challenging situations, in dangerous situations like COVID, because we feel a duty to act, but we each individually exercise our agency to engage in that process. But if some of us are not fit enough on a personal assessment to not be able to serve, then I think it's important to articulate that to your leadership and make it clear that you're happy to serve, just not on the front lines in the way that you would like to, but are definitely willing to do other things. Tell me what I can do to help out. Just don't put me in front of COVID patients because I'm at risk for really getting sick. And I think that's a very reasonable space to try to work through with your respective institution or leadership. I'm going to come down on the side of individual choice in determining whether you're willing to serve. The duties are there, but the individual has final decision-making capacity for that. No one can be compelled to serve against their will just because they have the skill set.
Susan?
So I would agree. I think that there are really a broad range of things that providers can do now to provide support and help and continue the practice. Our institution is heavily invested in telehealth communication with patients, and literally we have gone through our staff and said, who is at risk, and the people who are at risk need to be, doing remote from home, quarantine, telehealth work, and that's what we're supporting. And I would say another caveat, though, is that one of the hallmarks of this disease is that it doesn't always take the immunosuppressed or the feeble or the frail or the weakened. It can also dramatically affect the young, healthy, person who is volunteering or going for hazard pay. And so simply saying, I have a risk factor, so I need to be out, and you don't have a risk factor, so it's okay for you to be in, is not completely legitimate, because we know that young people without risk factors can be dramatically affected.
Yeah. Mike and Don and Arno, how would you approach? Let me just put a twist on it. And that you're in charge of the department. You have 15 people, and 8 of them volunteering, and they are taking care of them. 4 of them fell ill, and they are out. Now you have four people that they have to take care of it, and the other 7 say, nope, you're not coming in. How would you approach that?
Yeah, I mean, I think it's still, you got to respect people's individual decisions. I mean, I think everybody has their own level of risk tolerance. This comes up not infrequently with people who are pregnant, for example, and the risk to the unborn child and their health playing into it. And I certainly would have to would respect somebody in that sort of a situation. I think in a situation like the one that's presented here, it's also important to bring it to the attention of the health system, because it's possible that, for example, a small rural center may need to be in a position to start, if they don't have the capacity to care for these patients, especially if this individual is not really in a position where they could safely provide access to care for people at risk for COVID or having COVID, that maybe the hospital system as a whole needs to adjust what they're doing as far as where these patients go so they can be appropriately cared for. Because I certainly don't think it would be something that you could strong arm somebody in that sort of a high risk category into providing care for these folks.
Arno and Don?
To me, this particular example, this particular case is complicated because of the low resource that the area or town has, and that has to be addressed. It's not complicated with regard to the provider. If this provider has a physician that's at all competent, he would be forbidding him to practice in this context. So I think we don't help ourselves by putting at-risk physicians. That we're all at risk, and anyone can get deathly sick from COVID. This particular provider, if he contracts COVID, is much more likely to die. And I think that, as I said, I think his own physician would prevent him from practicing if he were given the opportunity to weigh in. So I think there's a limit to how much we can. There's a clear difference between, I have family members I don't want to infect, et cetera, et cetera. There's not a clear difference. It's a very gray difference, but this one seems more clear to me. This individual has much graver consequences of infection, or a much higher likelihood of very grave consequences, I should say. So you've got to just look at resources and figure out whether it's locums or whatever it may be. And yes, he can or she can do telehealth to contribute to care. But I think this one is not so great. I just don't think they can continue to practice in this setting.
Okay.
So can I interject here just a historical perspective?
Please.
I think that you know, we're frequently looking back at the 1918 flu, and then we make, you know, several centuries jump back to the bubonic plague and the role of physicians. And there is you know, there's a certain expectation of supererogatory behavior where we are altruistic beyond what, you know, what's reasonable to the point of foolhardy. And we have all kind of been trained in that narrative and are willing to go there. And so I think it's, like Don said, I think it's really important for our leadership to, you know, to support the idea that we have to protect our vulnerable members. And I think, you know, the other flip side to that is not the, you know, the altruistic physician who stays behind to care for the, you know, the plague victims, but the ones who, you know, the ones who run, who leave town, who go out into, you know, in the Middle Ages or the Renaissance, it was the, you know, the rural countryside in Italy and the country homes. And I think we're seeing that a little bit in the Northeast of America. And, you know, how we feel about physicians who so-called shirk their duty, and how we determine that over the next 6 months, I think is a really powerful thing for our profession. How we identify those who are at risk and who need to be protected versus those who are able and should be on the front lines. And, you know, history is a powerful teacher.
Very true.
That.
Very true. Andy, do you have a few slides for discussion? Yeah.
So the AMA Code of Ethics has a declaration of professional responsibility. This predates COVID, but was incredibly prescient. So this was written in 2017 or updated in 2017. Plagues and pandemics respect no national borders in a world of global commerce and travel. Through the centuries, individual physicians have fulfilled this obligation by applying their skills and knowledge competently, selflessly, and at times heroically. Today, our profession must reaffirm its historical commitment to combat natural and man-made assault on health and well-being of humankind. Humanity is our patient. So again, echoing many of the sentiments that have already been stated. There's a nice paper on the duty to care. There's a bunch written about this, but I particularly like a paper written by Wynia in 2010. This summarizes 4 major criteria that are our responsibility. Part of that is to take all of the reasonable precautions to prevent illness among us. I would broaden this to say that this isn't just healthcare workers, but all essential workers who are putting themselves in harm's way at this time. Yeah. This includes our sanitation workers. This includes folks who are working in environmental services, grocery store, and so on. We need to provide care for those who do become ill, recognizing that indeed people around us, our colleagues and our brethren, will fall ill. Some of them might not have the necessary insurance either, especially those in those service industries. We need to do something to mitigate malpractice and legal liability. Governor's executive orders that were endorsed by the White House do relax the standards of medical malpractice in the setting of a pandemic. Depending upon your state, these orders will look slightly different. But for example, many of them have relaxed the legal standard for malpractice from negligence, which is a standard that's easier to meet, than gross negligence, which is much legally harder to meet. So please look at your state guidelines if this is of interest to you, and recognize that there are legal protections for the work that we're doing in extraordinary times. And we also have to come up with a system to compensate those who are injured and die. There's a nice quote from this paper as well that says the duty to treat should be attenuated but not eliminated by the physician's responsibility not to become a patient him or herself. Yep. And the risks must be balanced against one's capacity to do good in the future. While heroism is to be commended, martyrdom is not called for. So again, I think that echoes much of what's already been said on this. But my 2 cents parallels those of Jeff's, who said it first, which is essentially that this individual physician should by no means be obligated to take care of these patients, and in fact should be commended for any ability to take care of other patients and to support the enterprise in this setting.
Very good, excellent. I completely agree, and I couldn't this was the best case to finish. Same as what you guys said. I echo what Susan said, and please read history. And I would say the first thing, I do read a lot of military history. The first thing they tell you in military is the most expensive, the most valuable asset in the field is the soldier itself. It could be an infantry soldier. It could be a pilot that's sitting on top of a $170 million plane. Doesn't matter. We can replace the plane and the equipment. It's much harder to replace a soldier. And think of yourself as people who are providing a service. And if you are not there, if you're sick, you can't do anything. So your safety is number one. And that's what's always been emphasized. Number two is what to do with people who give you the impression of they are shirking the duty. And that's very difficult. And I would encourage you to read history for people leaders who had different approaches. There's a heavy-handed tyrannical approach that, those guys are going to be punished and this and that. That has never worked. And if you look at great leaders such as Lincoln, such as Churchill to some degree, they were the ones who understood the concerns of these people, and they used a positive approach. They tried to use them as much as they could in other areas and just bring up the whole morale of the group and to kind of overcome those fears, as some of them are unrooted. And that's how they move forward. In general, most humans do the right thing most of the time. And I would encourage you to consider that when you're dealing with your colleagues in a stressful situation. I do have a question from the audience. Let me just read real quick. So the question is, the questioner is asking, I think that what confounds the issue even more though is that we know that many facilities do not have the equipment to appropriately protect physicians and healthcare workers. How should that impact the duty to treat? So that's an excellent question. What should we do if you are not provided adequate equipment and you're basically put in a hazardous environment? Anybody would like to take that up first?
So I think that's covered here under point 1, and I would make a very clear statement that we should not make martyrs of ourselves, and that having adequate PPE is a prerequisite to being able to provide this care. So I think that's a fairly straightforward comment. That will always put you in the indefensible position of choosing between yourself and your patient if it's truly an emergency in that setting. But assuming that's more of an elective setting, I would make an argument that having the adequate protection is critical. Yes,
and I echo that. And don't underestimate your power. To be honest with you, one of the reasons that I wrote that paper was I was looking up CDC for our own department, and I noticed that the CDC says aerosol generating procedures, and they don't mention anything closely with what we do. And everybody looking at it said, well, ENT, you guys don't do anything. Well, we do tracheostomy. We actually pack people's noses. We drain an abscess in the ER. Those are all aerosol generating, and nobody pays attention to that. And that was the night of us trying to write that and put in paper that these procedures that we do are high risk. And that's what the approach we have taken at NYU to convince people. It's very important to be productive and constructive, not criticism and negative. Unfortunately, we did have some pushback from some administrators that we don't need it, but that's mostly has disappeared. So I would say to the questioner that don't underestimate your power, do the right thing, and definitely push to get what you need.
I think this last article, another great case, Andy, really highlights the need of the physician or healer or nurse or the expertise is the most valuable resource. We can make more masks, we can, build more ventilators, but when we lose one of our own, and that means physicians and advanced practice providers and nurses, that expertise goes away and takes literally years to develop that expertise. I just posted a link to a really excellent New England Journal article from one of the big ethics team and medical ethics group at Penn. And one of the conclusions of that sort of outlining the ethical framework is that your providers are your most critical resource, and therefore that's a place to start building ethical decisions. If we're going to be putting ourselves, to answer that other question, if we're going to be putting ourselves at risk and we lose people, that is going to cut us off at the knees in terms of successfully, managing this pandemic. So if the PPE is not available, it needs to be available. It's not up for debate or argument. Making that happen in discussion there is the challenge, but it's not a subject of debate of whether or not you should just go ahead with something less than what we can best provide.
Very true. Okay, it's 8 o'clock. Thank you very much. Thanks to the panel. You've been most fantastic. Thank you all the audience. I still see 50 people in. Stay safe. Next week, we're going to talk about larynx cancer. Have a great evening. I'll see you next week.
Thanks, Bobby.
Thanks, everybody.
Thank you.
Yeah.
Thank you, everybody. So good to see you.
Yeah, good to see you. Thanks for joining us.